When it comes to the prevention of chronic diseases in Canada, three of the most important risk factors are tobacco smoking, excess weight, and physical inactivity. Now that's not news to anybody in this room, so it stands to reason that we should also understand something about the economic burden of these risk factors as well. One of the challenges with that, in terms of looking at the economic burden, is that if you look at multiple risk factors in the population, there are overlapping risk factors in individuals. So from an economic perspective, if you're looking at the cost of obesity or overweight or smoking, and then you add them together, you're double counting. And that's been a challenge for economists for some time. We, however, have developed a unique economic model that takes this challenge into account and addresses it. So we've taken into account this overlap. We developed it in Manitoba some years ago, and we have now enhanced that model. So we've taken current economic data, we've looked at prevalence for risk factors for tobacco smoking by intensity, we've included a flexible module, and we've made this applicable to all provinces in Canada. And this is what I want to talk about a little bit this morning in terms of some of those results. That work is coming out, I believe, this Friday, hopefully, in the Canadian Journal of Public Health. We've tried to coincide that with this conference. I want to spend just one slide on model development because I suspect this is not an area of huge interest in this area. If in this audience, if you are interested in, there are those papers, and I'd love to talk afterwards if you'd like to. But the focus or the approach generally was calculating the population attributable fraction, and so what that essentially associated with the risk factor. So what that means is how much is smoking causing a specific disease, 70% of lung cancers, for example. And then taking that information and understanding the economic burden, let's say, of lung cancer. And then finally, and in terms of the economic burden, looking at both the direct costs as well as the indirect costs. By indirect costs, we mean premature mortality, as well as short and long-term disability. And then, as I mentioned, adjusting for the risk factor overlap. So let's look at the results that we've come up for Canada. You're not supposed to see that, I guess. In fact, I can't even see it from here. We just wanted to show this one to you to show that there's quite a bit of detail, even in the summary. And we did this work for both, we broke it into both males and females and looked at this separately for that. But for today, we're just going to focus on the population in entirety, and hopefully you can see that a little bit more. So what this, if you look at it from left to right, what this tells us, for example, is that 17.9% of the population in Canada are current smokers. We mentioned that we broke that into light, moderate, and heavy smokers. Light smokers are less than 10 cigarettes a day, 10 to 20, and 20 plus. The 17.9 equates to about 6.2 million people who are current smokers in Canada, so still a significant problem. In terms of the calculated direct costs for smoking on average, it's $1,122 additional dollars per year to the healthcare system, and that includes physician, hospital, etc. kinds of costs. The indirect costs are about twice the costs of the direct costs at $2,303. So, and if you look up across the top, you can see that light smokers cost the system less, moderate smokers more, and heavy smokers the most. So this breakout is also important. And again, I think it's been fairly recent that we've been able to get the information that we needed to do this kind of modeling. If we then add all of this information together in terms of smokers, the economic burden associated with smoking in Canada in 2012 is estimated at $21.3 billion. And if you look down that column, if you can see it, if not, I'll read it. The economic burden associated with excess weight is $19 billion, and the economic burden associated with physical inactivity is about $10 billion. Added together, we're looking at $50.3 billion per year is the economic burden associated with these three risk factors. So we mentioned we did an adjustment for overlapping. So what's the impact of this overlapping or adjusting for the overlapping? If we didn't do the adjustment, the economic burden, if we just added them all together, they would be $57 billion whereas we came up with $50.3 billion, so an adjustment of about 13.4%. In the past, economists would just say, well, you really can't add them together because we know we're double counting, but we don't know how much. Or others would argue that the double counting is not that big of an issue. We've put a number on that now. Just looking at it in terms of light smoking and smoking again on the far left-hand side. As I suggested to you, that, and as you would expect, the costs go up with the intensity of smoking. What's also perhaps of interest here is that the cost, this is per individual per year, associated with obesity are about equivalent to that of a light smoker. The costs associated with overweight and physical inactivity are substantially lower. However, the prevalence of these risk factors are much higher, so when you combine them all, the costs are still fairly substantial. So this is based on a per individual basis or per capita basis. This one looks at combining the information for risk factors. So what we see here on the left hand is smoking. Smoking is still a more significant issue in Canada than is excess weight, but the two are becoming very close in terms of the economic impact. And then physical inactivity are about half that of the cost of these other areas, or the economic impact. We also were able to look at the economic burden in terms of the various disease categories, cardiovascular diseases, cancers, etc. So of the $50.3 billion, the vast majority of costs are still attributable to cardiovascular diseases. About 41.8% of those costs, or $21 billion. Cancer, about close to $10 billion, or about 20%. Musculoskeletal diseases go down a little bit from there, and so on. This is the same slide, just visually. Okay. One of the things that we then looked at is what, after now that we've got sort of an idea of what these costs are, the $50.3 billion, what would be the benefits of risk factor reduction? And we made a number, so we developed a module for this approach, and we looked at, the module is flexible, but we assumed a 1% relative annual reduction, a very modest reduction. So we're not talking about going from 10% to 9%, we're talking about going from 10% to 9.9%, etc. So that's your relative annual reduction. We assumed that obese individuals would move into the overweight category, and the same thing with overweight individuals into the healthy weight category. That the benefits would accrue within a year after moving into these categories, but that the benefits of smoking cessation would take longer to accrue. Okay. What we look at, and I'll just move forward through here, is that it can take up to 20 years for the risk associated with smoking to go down to zero, and for various types of diseases, especially for respiratory diseases and for cancer. Some of the others, cerebral vascular disease and coronary heart diseases, they approximate zero after about 5 years. And in fact, some of these risks don't go to zero completely, even after 20 years. So again, the message obviously is better not to start smoking, but if you do start smoking, stop. So we had to model this bit more complex relationship between smoking cessation and benefits. So we had to model this bit more complex relationship between smoking cessation and benefits. So what would happen if we looked at no change in terms of the prevalence and only a change in the population growth across Canada? And one of the things I should say that in this model, we used constant 2012 dollars, so we're not worrying about inflation, so the costs that you see are actual increases. So this just looks at the bottom bars, the top bars are what would happen to smoking in Canada if we did nothing at this point in time. Or made no changes from the current prevalence. And this is broken out in some detail by heavy, moderate, and light smokers. But the 6.2 million would increase to about 7 million smokers simply based on the population growth. If we made a 1% relative annual reduction, we could bring the number of smokers down from 6.2 million to closer to about 5.8 million. We've did the same thing. I won't spend a lot of time on this in terms of excess weight. So you can see we modeled this out over 20 years to make sure we had an impact and also to take into full account of smoking cessation. And the same thing for physically inactive individuals in Canada. So what this slide suggests is if you look at it in terms of the left side, so currently in 2012, and I just focus here on excess weight, about 42.9% of the population is either overweight or obese. That's equivalent to about 15.1 million people in this country. If we did nothing, if there was no modification in terms of the proportion of the folks with excess weight, by 2031, the number would go up to about 18.3 million folks. With a 1% relative annual reduction, we could reduce that number to 16.1 million people. A small increase, but still a modest increase. So again, a 1% relative annual reduction over time is a fairly modest goal, if you will. So if there's no change in risk factor, what would happen in Canada by the year 2031, sorry, let me back up, apparently the backup button doesn't work. So the costs would go from $50.3 billion to about $59 billion. And this shows that sort of graphically in terms of what would happen. If there was no population growth or change in risk factor prevalence, of course the cost would be stable, the bottom line. But with population growth, we see the increase in the costs, both in terms of indirect costs and a direct burden in Canada. So what would happen if we were able to implement whatever programs there are, and I'm going to say what they are, I don't exactly know, but if we were able to achieve a 1% annual relative reduction in risk factor prevalence, what would happen? What would happen essentially is that the cost would remain relatively stable despite the growth in the population in the country at about $50.8 billion. And if you look at it from this perspective, what you see there is a bending, if you will, of the cost curve. So with no change, it's the top line. With a 1% annual relative risk reduction, it's the bottom line. Over the 20-year period, we're looking at cost reductions or cost avoidance of about $58 billion. Those cost reductions or savings, if you will, are associated with smoking, $26.4 billion, physical inactivity, $20.3, and excess weight of $31.2 billion. We also, as I suggested, have modeled this for each of the provinces, and I suspect that this analysis might get me into a little bit of trouble in this room, but I'll show it to you anyway. What we looked at is each province and the risk factors for smoking and smoking intensity. Left side is British Columbia, right side is Newfoundland, Labrador across the country. And as you'll see that the smoking prevalence is the lowest in British Columbia. If you look at that for overweight and obesity, again, the risk factor or the prevalence of excess weight is lowest in British Columbia. By now you know I'm from British Columbia. The prevalence of physical inactivity, guess what? It's also lowest in British Columbia. Now, before the folks in the room from British Columbia, pat yourself on the back. Yeah, exactly. I see a little dance there. We are also adding alcohol to this model. And I can tell you that British Columbia will not look so good once we add on alcohol. So that's for next time. What you would then expect if the rates or the prevalence are lower in British Columbia, you would also expect that the economics to show that. And so on the left-hand side, you have the direct or the economic burden per individual with the risk factors, per capita in the province. On the left-hand side, these three risk factors cost the province of British Columbia just over $1,000 per capita. And on the right-hand side, they go up to as high as $3,000 per capita. So, and this is what's going to get me into trouble. What if we were able to achieve the prevalence of the risk factors in every province that we currently have in British Columbia. This would be the benefits, the economic benefits. These are the total costs. As you can see, Ontario just having a larger population. Essentially what we're looking at would be a $4.67 billion cost avoidance if every province was able to achieve the prevalence rates that are currently seen in British Columbia. I'll be flying back right after this conference to BC. Are these risk factor reductions achievable? Well, we know that we have been quite successful in Canada at reducing the risk of smoking, the prevalence of smoking, from over 50%, especially in males, in the 1960s to down to about 15, 16, 17% now. Has that made an impact on chronic conditions? Well, the answer is, if you look at specifically for males, because of the high rate that we started off, and we overlay age-standardized lung cancer incidence rates, you do see that there is a reduction in lung cancer, but there's a gap of 20 to 30 years between when this reduction in prevalence happened and when a reduction in lung cancer happened. We also looked at information on coronary heart disease from North Karelia, Finland. It's a well-known project that's been going on there for many, many years. And back in the 60s, they were having a problem with a lot of their young men dying of coronary heart disease. Much higher than Finland, much higher than anywhere in the world. They wanted to do something about it. They started the North Karelia project, and you can see it was then extended nationally. The bottom line, the dark line, is the age-adjusted rates for all of Finland. The green line is the one for North Karelia. And you can see that over time, they eventually achieved their goal of having the same age-adjusted coronary heart disease rates. But again, it took time. This chart starts at 1969 and ends in 2005, over 40 years. Another area that we looked at a little bit was melanoma, skin cancer in Australia, a big issue in that country. They started the SunSmart program in the 1980s, late 1980s, in Victoria, and then extended it nationally in the 1990s. And you can see again with the black line is the one in Victoria, is the age-adjusted melanoma rates for young folks, ages 0 to 49. And it would appear that rates are finally starting to come down, at least in Victoria, but not yet in the rest of Australia. So again, a long period of time, but it is possible to have an impact on chronic diseases if we modify the risk factors. So how are we doing in Canada? When it comes to smoking, as I suggested, as you know, we are continuing to see reductions in the prevalence of smoking. It's coming down at about a 2% relative change per year. So when we modeled 1%, we were aware of that. How are we doing in some of the other areas? Physical inactivity, maybe there's a reduction, perhaps in females, probably not in males. This is from 2003 to 2012. When it comes to overweight, pretty flat. And then the area of concern is obesity, where there has been an increasing trend towards prevalence, a higher prevalence of obesity, and particularly in the higher levels, so obese class 2 and 3. Now, there's something perhaps going on in the current year, 2012. Not sure about that yet. We'll have to see a couple more years down the road to see if some of those things, if that's just a statistical anomaly or whether those are the beginning of trends. So the takeaway message, two things. One is that even modest reductions in risk factor prevalence can have a significant impact, significant economic impact. And two, population levels changes involve a concerted, multifactorial, multi-jurisdictional approach that takes time. A fair bit, a lot of time. Thank you so much.